Okay, well, hello and welcome to the latest episode of the Accad and Koka report. Today we have the pleasure of having Dr. Fred Rincon. Dr. Fred Rincon is somebody that I've known really well for the last, I think it's been 7 or 8 years now. He practices at Thomas Jefferson Hospital, and he's a neuro intensivist there. Fred got his MD from Columbia. I graduated in 1996. He went on to do a Master's of Science of Epidemiology, and getting that in 2008 from Columbia University. He went on to do get another degree from the University of Pennsylvania. This was in bioethics in 2012. He also completed residencies in Lincoln Medical and Mental Health Center, the New York Presbyterian Hospital, and has done fellowships at New York Presbyterian Hospital as well as Cooper Medical Center in Camden, New Jersey. He's multiple board certified. He is board certified in neurology, vascular neurology, as well as critical care medicine. So quite an accomplished resume that you have here, Fred. So very, very, very impressive. And today we're talking about it's an extension of another episode, a very interesting episode that Michelle did. I was unfortunately unable to make it with a neurologist from California, right? Dr. Schumann.
Right. He's a retired professor from UCLA.
And that particular episode focused on brain death and what exactly brain death meant, and how perhaps the conventional approach to brain death was more pragmatic than correct. But Michelle, you want to tell us and give us a little synopsis of what you and Dr. Schumann discussed?
Sure. Just as a background, brain death was introduced to the medical community in 1968. There was a proposal by people at Harvard, a committee of clinicians, neurologists, ethicists, and whatnot, to come up with to declare people who had, extensive and irreversible brain injury, no evidence of brain function and no expectation that it would change or recover, to declare those people dead, even though they had certain other outward signs of life, like a heartbeat and, being warm and that sort of thing. And there were two reasons at the time invoked for doing so. One, they said that it was it was actually quite ambiguous in that paper. On the one hand, they didn't call it brain death, but they called it irreversible coma. Okay, so they wanted to tell patients that people with if their loved ones were in an irreversible coma, that they should be declared dead in a way. One, because they thought at the time that the intensive care was actually masking the reality of death. They thought that actually a complete destruction of the brain was actually a form of, or essentially equivalent to biological death, right? And that the intensive care somehow was masking this, but actually there was not. A brain dead patient is a disintegrated patient. Mm-hmm. And the disintegration was not evidence to the senses because of the intensive care, but it was just a matter of time. And to spare the family the agony of waiting in hope, we should declare those people dead and then withdraw the care. But of course, the other argument, or the other benefit of coming up with this concept of brain death was that organs could be harvested, because that was the beginning of organ transplantation, and organs could be harvested and used for heart transplants and whatnot. So that was proposed in the 1960s, late 1960s. It took about 10 years for the legislatures across the country to implement that idea into laws. And finally, the federal government itself came up with the Universal Declaration of Death Act in 1982 that essentially codified this into law. so that if people are diagnosed as having irreversible complete cessation of brain function, so-called brain death, that would be the equivalent of death diagnosed by traditional traditional means, meaning the absence of pulse and respiration. Okay, and at the time, again, they said that those two events biologically are the same; they're identical. That having a non-functioning brain is equivalent to having no pulse and being biologically dead.
Okay, yeah.
And so what happened is that Alan Schumann, who was on the show on our podcast a few episodes ago, was very interested in that question. He was actually in favor of that argument, that brain death is equivalent to biological death. But in the course of his experience and practice, he started to collect cases who, for one reason or another, were not, didn't have their intensive care withdrawn. They were maintained on the ventilator, and they survived. They survived for a long, long time, much beyond the expectation, which at the time, the expectation was that, the body is disintegrated and it's in the process of dissolution. Well, a lot of these patients who were kept on a ventilator, or at least some of them, could be kept on for years and years, and not only be kept in that state, but also show signs of biological integration, meaning some of them would go through puberty. If they had this brain death event as children, they would go on through puberty. Others would be cases of pregnant women who actually were able to gestate fetuses, even though they were quote unquote brain dead, and therefore, in a sense, they were a body in at least the argument was that they were a body in process of dissolution. Well, at the same time, they were able to gestate, a baby to term. And so he accumulated, hundreds of cases, I think 100 or 200, and published them in the late 1990s, and publicly made an about face because he was a prominent defender of brain death. And then he said publicly, I do not believe in this concept anymore. I think this is it's incorrect to say that brain death is equivalent to biological death, if you will. And he attracted the attention of people at the time, but by then it was no longer at the forefront of medical debates. It was more in specialized journal in neurology and so forth. And people, for the most part, I think, have accepted the fact that brain death is not the same as biological death, although there's some debate about it. People, hem and haw about it. And they say, well, maybe it's not biological death, but maybe it's no longer a person, and we can continue to proceed with organ harvesting, or we can continue to proceed to tell the families that essentially those patients are dead, even though biologically it's not the same. And that's essentially that's the gist of it. Did you have anything to add, Anish, to that to the conversation that I had with Dr. Schumann?
No, it was a fascinating conversation. Something we don't spend a lot of time thinking about. You just I don't do this a lot. And, Fred is going to comment a lot more here, but on it. But I had a simplistic version as well. That when you met these certain brain death criteria, whether it be the apnea test or whatever, the cold caloric test or whatnot, that I was like, all right, I guess you're brain dead, and that's it. But Fred, this was eye-opening to me to hear, Dr. Schumann's conversation with Michelle. What are your thoughts on all of this?
On the concept of brain death?
Yeah, and what Dr. Schumann, what Dr. Schumann and Michelle are saying. I mean, is there really such a thing as, are we too focused on the definition of what brain death is to do things that we want to do but that are pragmatic,
So when I talk about the topic, right, when I talk about the concept of brain death, I usually start my talk or my conversation with a slide. I don't know where I got it from, but it basically says, when are you dead, right? And the answer is when your doctor tells you that you're dead, right? And that sort of like highlights the importance, right, of physicians in terms of arriving to the conclusion that somebody has died. And historically, as we have mentioned here in this podcast, right? You were considered dead when your heart stopped, and that was a concept that was sort of like preserved and sort of like defines the concept of cardiac death. When you don't longer have a pulse, and your heart stops and you die. But then the lingering of these patients in the intensive care units and in the wards with this coma, right, with no neurological activity, led to this research, by Harvard and some other investigators, primarily in France and in some other parts of Europe, to arrive to this definition, of death by neurological criteria, and which is described by the UDDA. And that's really what the discussion over the last couple of years concentrates on, right? It's really brain death an achievable concept? Is that really a pragmatic concept, right? To define death? And that's where the question is sort of like focusing on right now. Because the definition is very clear, it's irreversible cessation of whole brain function. We're talking about death by neurological criteria right now. And I don't want to undermine, the definition, it's the way that we practice. We have a, expert opinion based way to arrive to the conclusion that the patient doesn't have a neurological function, right? But to one point, right, when I'm doing these evaluations at the bedside, right, can I really arrive to a conclusion that there is irreversible cessation of whole brain function? And that's where I have a problem. And if you consider how purists or attorneys that interpret the law, right, because this is a law, right, how you interpret the law, right, people really attach to the letter of the definition, right? So in any litigation, in any case that you litigate in front of courts, right, attorneys really pay attention to what the definitions are and what the letters are, what the words are, what is the meaning of irreversible cessation of whole brain function. And I also have a slide where people have interchanged the term irreversible for permanent, for example. And those are two different definitions in English, in the Anglo-Saxon language, right? Permanent is different than irreversible. So just to give you an example, even for cardiac death, if I arrived to the bedside where a patient, heartbeat is sort of like slowing down, and I see the flat line, and then the nurses ask me to pronounce the patient. And then if I wait, a couple of seconds and I see a flat line, I know that if I start resuscitation and if I start CPR, and eventually if I get a rhythm, if I, shock the patient, I can get that heart back, right, to where it was before. That's what I call a permanent cessation of a function, rather than a irreversible cessation of a function where if I wait 5 to 10 minutes, right, I might not be able to get that heartbeat back. So it's the same thing with the brain, right? Are we doing these evaluations in a process of a dying brain where we still have some function, but it's minimal, and we cannot test at the bedside with clinical exams as we do routinely, right? And we cannot arrive to that definition of irreversible cessation, which means that the brain cannot get back to where it was, right? And is of the whole brain. So I don't think we can get to that definition, and that's where we have a discussion among bioethicists right now, right? That perhaps, what we're doing does not fit the definition. We may need to think about different ways of defining neurological death or death as a whole, right? And that's how I sort of like have arrived to this conclusion that we have a problem with the definition that is not pragmatic, in the sense that we cannot, achieve that with the ways that we do our evaluations at the bedside.
So you're saying that,
yeah.
So you're saying that these clinical criteria that exist, right? I mean, the apnea test, I'm embarrassing myself here. What are the other things that you guys do?
Well, so to arrive to the conclusion, right, that the patient is brain dead, you have to satisfy 3 main criteria.
Yeah.
Patient has an irreversible and a devastating brain injury that leads to cessation of neurological function, right? Mm-hmm. You must be in a coma that is explained on the basis of that injury. 2, you must have no neurological function. And the way that the law describes it, right, is whole cessation of brain function. But the only thing that we test at the bedside is in reality the brainstem, right? There is no way of testing cortical function, with a clinical exam. Just by definition, you're in a coma, your hemispheres or your reticular activating system may be down, but the exam that you do at the bedside is just brainstem. This is why the British, right, their concept of brain that is primarily focused on brainstem exam, and their criteria is just based on the brainstem. It's not really based on anything else. And then 3, you have to have a lack of response to a challenge of CO2, or what we call an apnea test. So if you fulfill that criteria, right, at the bedside on the basis of clinical exam, you can say the patient is dead by neurological criteria. The problem is, can you really say with those 3 criteria on the basis of clinical exam that takes only 5 minutes, right? Can you say that the cessation of brain function is irreversible and is for the whole brain? And the answer is probably not. I, for example, see only, I would say probably 30% of the cases, probably less than that, evidence of pituitary dysfunction, like diabetes insipidus, right? That doesn't happen in everyone, but if you think about the pituitary being as part of the brain, right, then how can you say it is irreversible cessation of whole brain function when there's still segments of the brain, even if they are vegetative and minimal, in terms of the degree of function that they have, right, is that you cannot really achieve to that conclusion. They have done these cool pathological experiments, right, where they have looked at postmortem brains in these patients that have been cataloged as dead by neurological criteria, and they have found that there is still viability of some neurons in some areas of the brain. The question is, right, is that really meaningful in terms of, can the patient really survive with those neurons that are still viable, that don't have that much of responsibility, right, in making you a human being? And the answer is probably not, right? So then the question is, are you really dead, when you have severe brain function and you're not able to return to your state as a human being, rather than, trying to sell me this idea, right, that when I do these 3 components of the neurological exam, I can say, yeah, your whole brain is gone, therefore you're brain dead. My question is probably, we need a better definition in the sense of how we define death. And that's like the liberal approach that, I take on this problem, right, is that perhaps the way that we are trying to arrive to the conclusion is not ideal or truthful, right? Perhaps I should say, in a better way to a family or a patient, right, the degree of brain injury that this patient has is not compatible with meaningful life as a human being, right? Yeah, there are still some areas that are preserved, but I don't think they will have any impact in the way that he was before. And perhaps for some people, that may be considered as death. If you ask this to, societies, right, that are similar in the sense that of technological advancements, right, the law, the societal construes that they have, like Japanese society or like the Belgian society, right? They're similar in the sense of the same sort of like principles that we share in terms of freedom and citizenship, etc., right? Religious, beliefs as well. We are no different than them, but they have a totally different concept of death, right? And when it comes to organ donation, is even, far more.
How do the Japanese differ from us, Fred?
So they don't have the same criteria of brain death that we have, right? For some, you don't need to be death, right, by neurological criteria to donate your organs in Japan, for example, right? And if you have severe brain injury, but you're not considered dead under our criteria, right, you can still donate your organs as long as
Who's deciding that? The patient obviously is not.
Or the families.
The families.
Right? Yeah, there was a recent case published by the New York Times on these. It was a toddler, but it was an infant, right? That has severe brain injury, right? And I'm gonna discuss a little bit about another concept, right, that we have, which is the dead donor rule, right? Which is not a law; it's just a requirement of when you can donate organs. So basically in the US and its jurisdictions, you can only donate organs as long as you're dead. That doesn't apply in other jurisdictions. People can donate organs even if they are not dead. So this New York Times, article on this patient, right, that happened to be a pediatric patient that has severe brain injury, could not be cataloged as dead by any criteria, right? And because of that, couldn't donate organs. The family, and primarily his parents, were saying, well, we know he's not going to be the same person, right? He's not going to survive this brain injury. It's futile to continue any therapy with him or her. And so why can't he donate organs? And then the answer is because he's not dead. And then they were like, but that seems to be preposterous, right? We can help many people, right? We know our son, I think it was a boy, our son is not going to be the same person, but in the process of him dying, can he be dignified in a process that we are proactive, that we're in agreement with, which is organ donation? But it didn't happen because he wasn't dead. But had this kid been in another society, right, like some jurisdictions in Europe or even Japan, he could have donated his organs. He would have gotten to the OR. He would have gotten harvest, for many organs, and he would have died in the operating room.
So, Michelle, what do you think? Do you think that the definition for death, should be a more pragmatic one that individuals decide? Individuals and their families.
No, I'm uncomfortable. I'm comfortable with that. If you start by saying if you admit that death is subjective, right? Then I can declare you dead, right? You look a little dead to me, and I think that's very dangerous. And so I want to be a realist. I think that there is in nature. It's not death. The difference between being dead and alive is not in the mind of the people observing the event. It's actually out there in reality, right? It's in the world. There's a distinction between being dead and being alive. And I think it's important for us as doctors to respect that reality, right? But I think, Fred, you're correct that in many different cultures and even in the U.S. right now, we seem to be comfortable with making death a little bit of a judgment call, where we decide that somebody is sufficiently injured to be declared dead. But I think the first thing is that if we're going to go that route, we should make it clear. But right now, the law actually doesn't say that. The law says that if you fulfill these neurological criteria, then you're really dead, biologically dead. So I think that's wrong. That's wrong. It should be corrected, and then we should be honest with patients. And as you said, Fred, I think maybe some will say, well, yes, we should still, if the patient has irreversible, brain damage, and he should be or she should be allowed to die and have the organs donated. But I think even here we have to be careful, because who are we? Even parents or families, who are they to decide that somebody can be? Because it's the process of organ donation that will kill the human being, right? So it's a human being.
It'll kill only if they're not. If you don't think they're dead, meaning if you consider them dead, then
right.
So this happens. Michelle, if I have a large stroke, who you are is different. Who I am. I essentially died with that stroke, meaning I am now a different person, right? So if I say right now, I say right, but I don't agree with that. But if I say right now to my family and friends, and to you two witnesses here that, if I have a large stroke and I'm not the person, and I can't do a podcast, Michelle cannot whip me to do a podcast Monday and Thursday every day. If I'm not able to do that, I don't want to be sustained on any life sustaining type of therapies. Why would you not want to respect my my wishes?
Yeah, no, that's different. We don't have to sustain you. You can certainly refuse life-sustaining therapy and be allowed to die, right? And you can go on and then die, and then you will be truly dead. But you cannot say, because my brain is not functioning, then I'm no longer myself. That's a contradiction in terms. It's nonsensical. Or if you want to say that, then, what keeps you from saying, well, I'm really a kangaroo right now. And and I want to be, treated as a kangaroo. And
well, here's the problem. The problem is, and I've seen this happen more and more now, actually, as the neurointensivists have gotten more involved. I mean, neurointensivist as a specialty is something that's really taken off in the last 5, 6, 7 years, would you say?
Yep.
Right. I mean, there's like tons of neurointensivists that were, we never saw them before. Before it was like the MICU guys, who would open up the neurology book every time somebody would come in, or the neurosurgeons would be managing it. Now we have a dedicated neurointensivist. And with that, I've seen neurointensivists fanning out to do consults in other intensive care units. So whether it be the medical intensive care unit or the cardiac intensive care unit related to patients presenting with cardiac arrest, right? So they present with cardiac arrest. There's significant downtime. They're intubated. Middle-aged person on dialysis as well. There's organ dysfunction, multi-organ dysfunction, and you're coming to this decision about, well, now it's been more than 5-6 days. The patient has clearly suffered a significant anoxic injury, and people want to punt the decision to someone, and the places they're punting the decision to right now are, I think, in terms of, well, what's the neurologic prognosis? What should we do? Should we keep going? Should we stop dialysis? Should we trach and peg? What's the neurologic prognosis here? Is this person going to, in 6 months be, coming back, walking around? And I think if you go down the route Michelle is leading us to, I think what's going to end up happening is a vast number of patients trached and pegged in minimally conscious states in nursing homes. And I don't think that's what those individuals would ever have wanted for themselves.
Right, but the problem there is not, it's not because of our definition being wrong. It's because, there's a third-party payment system that enables that sort of thing. The other way to do it is say, to tell to families, this is the case. If we didn't have this, these welfare programs, throughout, all developed nations, and families would have to decide, do we have the resources, do we have the personal resources to continue this when there's a lot of hope, and instead, we have a family to raise, we have kids that needs, education and so forth. And this patient is very ill, but we don't have the resources to keep them going, and we're going to let them go. And I don't think there's anything immoral about that. I think that's actually perfectly moral.
But then you'll have people that can pay more. Obviously, folks that can't pay will. I
I don't think it would have anything to do with wanting to pay. Whether people are attached and want to use disproportionate, you would use the term disproportionate means to keep a human being alive. If they have the means and they want to do that, they can do that. But even if they have the means, they may not wish to do that. They may say, we have the means, but those means can be used to other ends, and we choose not to use them to that end, and we're going to let our brother or sister or mother, we're going to let them go because they've had a severe injury, and we're going to let them go, and they're going to die, and we'll bury them, and then that'd be the end of that. And I don't think there's anything immoral about that.
But then you're not really deciding on whether or not to sustain life based on probability this person will get better or not. You're making that decision purely one of ability to continue to pay for this person, right?
Well, no,
essentially at some point you run out of resources.
Right. I mean, they're both together. You make a judgment. If it's a big stroke, and, we know, this is our state of knowledge today, is that you're not going to recover, or the patient is not going to recover. You make that judgment, and then you say, well, that's our best judgment, and we cannot, expend, use disproportionate means to keep that person alive. We're going to let them go, and let history and nature follow its course, because this is really what you're doing. You're letting nature follow its course. Nothing immoral about that. Or you say, well, I have the means to keep that person alive, and I'm going to do it, but I'm not going to burden others. I'm not going to burden society or the taxpayers, and I'll do it with my own personal resources. And you can do that as well. And I think I think there'll be a mixture of those two decisions. But that would be, yeah.
Oh, sorry, Fred. What do you
Yes.
what do you think about my concern that making it now that you can't even say based on apnea test and severe injury that somebody's brain dead, or sorry, somebody's dead. If you make that gray, are you worried like I am that we'll have, we'll expand the number of decrepit. I shouldn't say decrepit. I mean, expand the number of minimally conscious folks in nursing homes that, is that something that you worry about?
I at first, I don't think we cannot say somebody is dead by neurological criteria with the current criteria that we have. I think we can do that, right?
Right.
I know I just want to clarify that I didn't, want to mean that we cannot. What we cannot do, right, is to arrive to that strict definition that is prescribed by the law, which is the reversible cessation of whole brain function. That's what I'm saying, is that, I feel uncomfortable saying there is this irreversible cessation with this clinical exam that I'm doing. That's the
right. But by saying that, well, I don't know if we can totally say it's irreversible. If you tell a family that, I mean, what is a non-medical layperson family going to do with that information? They're going to say, go, keep going.
So that's the problem that we have with the law, is that for some practitioners like me that have this philosophical, a problem, right? We feel that, we are not, and this is why you need to be careful with this sort of like, criticisms or critiques to the way that the law is written, is that we are undermining, right? The trust from the society on the way that we perform, right? Our diagnosis of death by neurological criteria. But the reason why we're doing it, right, is perhaps to satisfy a societal need. It's not just organ donation, it's also closure, right? And it's also financial interest that we have, that cessates when you say, or ends when you say, the patient is dead. So the criticism that I have is a technical criticism. I think that the concept of brain death, right, in my mind, means it's just a terrible brain injury that is incompatible with any meaningful type of life, right? And that's sort of like the idea that I have when you examine these patients and they're totally devastated, right? They don't have any function whatsoever, right? I don't care if there's just a little bit of function in the retina or in the
but Fred, why is that less meaningful than somebody who is in a vegetative state without fulfilling the criteria for brain death?
What is that?
Why is it less meaningful? I mean, because if you say that brain death, is there's no meaningful, ability to recover. It's also true of people within a vegetative state, right, or minimally conscious state, who don't meet brain death criteria. Are you going to say also those are should be declared dead? Right?
No, I'm not. I'm not saying that.
Right, but I mean, or they should be declared. So, because there's no demarcation between degrees of severity of brain injury, right? And so, where do you draw the line as to what is meaningful or not meaningful, right?
Exactly.
I mean,
so that's the concept that is extremely liberal, right? That has some problems with some practitioners. That can we allow, right, the person itself to define, that sort of like level of what people would consider, death. It doesn't have to be on the basis of neurological criteria. It could be on the basis of functional status, and that's the liberal concept, right? That terrifies people like you, for example, right?
It does. I mean, I think it doesn't terrify. It doesn't terrify me, but I think it's wrong. I think it's. I mean, it does terrify me in a sense, but I know we do it already. We do it, in many different ways, and I think it's wrong.
Well, but Fred, what do you think about Michelle's not solution per se, but Michelle's approach to this would be to say, look, I mean, the problem here is that third-party systems allow this kind of indefinite support of these folks, and we should, if we didn't have this third-party system operating, kind of sustaining these devastated folks,
training your patients,
then they'd have to make a personal decision and say, look, either we support our family or we continue to pour resources into this other, this thing. Are there any ethical issues with that approach?
I don't think there are any ethical issues. I mean, healthcare is driven by the payer system, right? And this is why practicing in different jurisdictions, is different. But I always have this concept about ethics. You practice ethics according to the jurisdiction where you are. So it would be extremely unethical, right, with the current definitions that we have in the United States to say what you're saying. But if you move to India, right? If you move to South America, right? Some individuals will say, you know what? Our grandma just died. She's in a vegetative state. She's not the same person. She's dead to us, right? She never wanted to be in this situation. So enough is enough. Yeah, we want to feed our family. And today we are stopping, medical interventions. And that's a total different definition of death, right? That is based on societal needs, The societal needs that we have here that makes it define death in different ways, right, are different, right? We need to define death for insurance issues, financial issues, for, yes, closure to the family, and then finally for this organ donation, which is, yep.
So Michelle, your argument rests on utilitarianism, on net good.
No, not at all. Not at all. I mean, it's. But I hear what Fred is saying, and I think he's correct in his sort of sociological. You're correct, Fred, in your sociological analysis. But really, that's not. I mean, again, I go back to let's be realistic. By realistic meaning, let's call the cat a cat, and a dead person a dead person, and because if you start to say, well, our ethics are going to be relative to our environment. Well, if the law changed, we're going to have different ethics, and if we, I think to me that's problematic. I think the law should reflect reality. Our ethics should reflect reality. I think we should, understand what, and certainly something as fundamental as that. The notion of life and death. It can be picked up by, so one living organism can identify another organism as being living. It's extremely conserved across all species. A baby can make a distinction between something that is dead and something that is alive extremely, extremely precisely. Much more. I mean, it's one of the most conserved, biological powers across all species. But yeah, here we are, in the 21st century or late 20th century, saying that no, we can play with that definition, because if we play with the definition of death, we really are playing with the definition of life, right? So we're saying that life can be, determined a little bit by consensus, by convention, that sort of thing. And I think that's bad. That means we can decide, we can judge who we can declare in a way either subhuman or non-human or non-existent, and I think that's really highly problematic.
I know, and the example that I have, right, of how different jurisdictions approach this problem is just the ALS patient, for example. The patient that has ALS and is in a terminal situation, and you're seeing these case reports more and more, where ALS patients are actually defining when their time of death is, right, and how the expectations are going to be, and a lot of those people are like saying, you know what, I'm dead, I cannot do anything I was doing before, and these are my wishes, right? So right. It's a philosophical definition, right? And I sort of get it, right?
No, it's not a philosophical. It's a figure of speech. When they say I'm dead, it's a figure of speech. Mm-hmm. They're expressing, a wish, but you cannot say I am dead. That's a contradiction in term, because when you're dead, you don't say I, right? So when they say I'm dead, it's a wish, and then society here, we've decided to grant them their wish, and that sort of thing. But it's not. It doesn't reflect a clear-cut, very strong biological reality, and that's my beef with it. That's my beef with the whole thing. That's my beef with a lot of the bioethical community getting, playing along with these redefinitions of things, sort of willy-nilly, to adapt to, they say, well, we're a modern society and therefore we have to, our ways, it's medieval to think about clear-cut definitions. No, clear-cut definitions are in reality, they're not, we don't make them up. They're out there, and we need to conform to that. Otherwise, a lot of unhappiness ensues.
Yeah. Well, this is a good conversation. Clearly, this is certainly there's a lot of debate about.
It's fascinating, right, to think about death. From the thermodynamic principles of entropy, right, to the philosophical, definitions of death, right? I mean, and you have these opposing sort of like challenging views, right? But I just want to comment, on these definitions of death by neurological criteria, right? They're going to get challenged more and more because of this lack of accuracy, right? Lack of sensitivity and specificity, and core systems in states are actually challenging this concept. And I think
I want to make a comment also about the apnea test itself, which has is being challenged, and because suppose you're not sure if the patient is quote unquote dead or alive, and then you do an apnea test. Well, an apnea test is not benign, right? Do you need to get informed consent? I mean, you're going to let that patient, who might have a little bit of residual brainstem function, you're going to expose them to lack of oxygen for 2 or 3 minutes or however long it takes to do that. So all of these are quite problematic. And I think you're correct. In terms of the scientific definition of life, there's no such thing. Yes. I wrote a paper on brain death, which we'll put on the show notes. And I have a reference in that paper in my process of researching it, where there was a symposium of scientists in 2008 or 2010 that took place in France about really how to define life, which was important for certain fields of biology. Certainly for what's called astrobiology, where they're looking for, if life exists in other planets, and also for, evolution, how did life emerge, on Earth? And there's absolutely zero consensus. I mean, you have hundreds of different opinions about how to define life, which is a real problem for those scientists, because how are you going to, recognize that you've found life, on Mars or somewhere else, if you're not sure what you're looking for, right? So there's no definition of life, because, at least not according to reductionist principles, on which frequently science bases itself. There's sort of a marriage of convenience between reductionism or mechanicism, if you will, and science. But the bottom line is that it is a philosophical question if you're going to study it philosophically, and it requires some kind of philosophy of nature that can take into account that real distinction between living beings and non-living beings, and the traditional reductionism, mechanism, atomism of that we're sort of familiar with can't do that. It really does not have any way to make the distinction between what's a living organism and what's not a living organism. So, but it's fascinating. I think I encourage doctors to think about this more. I think it's very important, because we are the arbiter of that question, all the time, right? So it's important for us, and not leave that to the specialized bioethicists who are out there and coming up with their theories. But I mean, they're important, of course. I mean, it has to be a conversation. But for us, we live that reality all the time, and then we are the ones conveying that information to the patient. So perhaps if we take our duty to the patient seriously and to their families, we should pay attention to that question.
Perhaps we shouldn't. I mean, we've set ourselves up as the arbiters of what is death and what is not death,
well, we don't. Well, that's right, but we're not the arbiter of defining what death is, but we're the arbiter of recognizing it. People, come to us.
Maybe they shouldn't.
Can you tell us? Can you tell us? Well, no, I think they should, because we are the one who can. We have the experience. We deal with sick people who die, so we have the experience. So we can say, yes, we recognize that. X has happened, that, you know, this body here is no longer alive, it's dead. Okay, that's, you know, that's our job. We have to assume that responsibility. But we shouldn't, if that's puts us in a difficult position, we shouldn't get out of that position by redefining what this is and saying, well, let's do it in a way that's most comfortable for society.
Yeah, no. It's not that I don't appreciate the the ALS story, and I mean, I you know, as a resident, I had a very close friend who had a sister who had muscular dystrophy, and it was just an amazing story of, you know, severe muscular dystrophy, just massive wasting, and you know, life expectancy should have been 12 or 13 years, but, you know, she lived till she was 34, 35, and those last 4 or 5 years were, you know, incredibly tough. And I remember thinking multiple times that, you know, what is the value here? You know, I mean, there was complication after complication because all these PEG tubes and infections at the PEG tube sites, and, you know, eventually a pacemaker was required. And I mean, it was, I mean, you know, maybe 200 days a year spent in a specialized children's hospital. I mean, it was brutal. And to me, to my value system, right, as, you know, as a guy who was running around I was a resident, I was like, you know, what are we doing? What's going on? But then, you know, I would see her on her birthday, and she would be smiling, enjoying life, so happy, and she was dictating and guiding a lot of her care. Because of course the terribleness of muscular dystrophy is that your mind is completely intact. And so, you know, I recognize
beyond that, you're right, Anish. But beyond that, I'll say, even if somebody's in a coma, brain dead, and you say, well, what's the value of that? I don't want to be that person. But then you don't pay attention. I mean, if you pay attention to what's happening around that person, you may have families that now come together to help out. You may have caregivers, you may have reconciliations. So, you know, to judge the meaning just by looking at this being in isolation. And so, I appreciate what you're saying. I'm just going even beyond that.
But
there's a lot of things that are going on, so that the value of a life cannot be just simply judged, you know, on narrow criteria. I mean, there's, you know.
Right, but what I'm saying is that we, as the physician who has met this person for 10 minutes and Fred is doing, you know, a 5-minute exam on to decide on whatnot, we are not in a good, perhaps we're not in the best position to decide on.
Oh, right. Yeah, you're right.
So I'm saying
on the question of value, on the question of meaningfulness and value.
Right, because it's so individual and dependent. It goes from person to person. It depends on culture, you know, Japanese individuals. So it pushes back against I don't know, this idea of when, you know, what is living and what is the value of continuing to live, I guess. And whether or not you want to say, you know, this is life, this is death, we've crossed up this line, this arbitrary line that we draw somewhere.
No, it's not arbitrary. That's what I'm saying. So it's not arbitrary. So I want to make actually our life simpler, because, you know, if the families come to us and say, is this meaningful or not? Then we say, you know, we can't say. It's not for us to say.
It's not. It is for you to say. Right. So.
Right. It's for you to say. If now you're responsible for your loved one who's very sick, and it's for you to say. Yeah. But for us, it's for us to say if this person is dead or not, and, you know, that's not a dead person. That's a living human being.
Yeah, we should biologically. Yeah, yes. Right,
so I'm trying to make things actually clear cut. I'm trying to avoid the grayness of things, and you're right, because we're not in a position, we don't know all the circumstances.
All right. Wow. So
and part of the problem, right, that I see also, right, is that as physicians, right, we think as that as an unnatural thing, right? We've been trained, right, in this sort of like you know, mentality that we need to preserve life, right? And I agree with that concept, right? But we fail to have the discussion with patients about death as a regular, natural process, right? I mean, nobody lives forever, as much as I love that song by Queen, right? But the problem is that we never face with families or patients, you know, hey, let's have a discussion about that. You know, what do you think about it? You know, when your time comes, you know, what is death for you? You know, what is the meaning of end organ damage? You know, what is the meaning of futility? We never have those discussions with family, right? So
yeah, no, so absolutely. So It's a great discussion here, guys. We'll wrap up. We're ending. I told Fred 40 minutes, and we're like 10, 15 minutes. So it's a fantastic discussion, Fred. Thanks so much for coming on.
Yeah, you're welcome.
I hope we'll have to have you back on to talk about some other stuff too.
Sounds good. Yeah,
Alrighty.
anytime.
Thanks, Michelle.
All right. Good night.
All right.
Yep.
See you guys soon. Bye.
Yep. Bye-bye.